people. To kind of give a little bit of background on Ali's talk, as you guys know, we have been managing these ECMO patients, right? And so these COVID ECMO patients. And so recently we had a meeting with the surgeons and to try to make sure that we're all on the same page instead of management. And so after that meeting, I sent Ali the notes that we had, and hopefully he can kind of go into more detail about the discussion that we had. Okay, so thanks, Ali.
Cool. All right. So since the pandemic started, we've been managing these patients pretty consistently. There have been like a few questions that have come up in my mind that in regards to their management, and I felt that it would be appropriate to kind of look them up and kind of talk about them a little bit, specifically in regards to the COVID experience. So a little bit about it. I'm going to talk about the introduction, some of the landmark trials that have come up in regards to ECMO. ECMO in regards to the pre-COVID era that we've had, the experiences we've had at the institutions throughout the United States and across the world in the post-COVID era, some of the mortality data that's come out throughout on ECMO, and then some factors associated with mortality, and then some of the mechanical ventilation questions that I've kind of always that I've wondered about when patients are on ECMO. Just a little bit from the beginning, obviously extracorporeal membrane oxygenation, this technique has been around since about 1972 when it was first successfully utilized in an adult patient. It's basically utilized to provide prolonged cardiac and respiratory support in patients who are unable to do so on their own. For the purposes of discussion, we'll be only talking about VV ECMO only. So since its inception, approximately 4 randomized clinical trials are the only ones that have been conducted looking at the efficacy of ECMO in regards to acute respiratory failure. And of those 4, only 2 out of the 4 are actually relevant and current at this time. The one being the CAESAR trial and the second being the Eolia trial. So kind of looking at it from the ELSO is Extracorporeal Life Support Organization established back in 1989, nonprofit organization where most institutions or centers of excellence that that regularly do ECMO do transmit and give voluntarily their information to it, and keeps a very large database in regards to their outcomes. So and their use. So this graph that I kind of got from their website looks at that, shows that ECMO utilization until about 2009 was pretty low, wasn't that high, and then it kind of exponentially increased starting 2009 onwards, and culminating in the 2018 Eolia trial. So what happened essentially in 2009 was the main trial was the CAESAR trial, which came out, was a large randomized clinical trial. The question that they were answering was, is ECMO safe and effective compared to conventional mechanical ventilation for ARDS? It was a single center trial done between 2001 and 2006 in the United Kingdom, looking at conventional treatment versus referral of patients to an ECMO center. 90 patients were utilized in both the treatment and the control arm. What they were looking at was 6 months survival without severe disability. In the study that they noted that 63% of those patients who were 63% who ended up going to the ECMO centers did well versus 47% on conventional mechanical ventilation. As you can see in the graph on the bottom right, there was a pretty significant statistical difference between the two. Some of the major criticisms that have come from this study was, number one, it was a single center study. Number two, that in the control group, only 70% of those patients ended up actually receiving lung protective ventilation versus 90% of those who got it in the intervention arm. And third was that, in those that were in the intervention arm, not everybody actually ended up getting ECMO. It was just that they were referred to an ECMO center. So the question was whether is it the referral and the fact that they have a higher volume, and maybe that was somehow associated with improved mortality. So it was right after 2009, the H1 influenza pandemic hit, and that really took off the utilization of ECMO. It resulted in broad adoption of ECMO and increase in these registered centers. So the study done in Australia and New Zealand back in JAMA of 2009 really clinched like the effectivity of it, in which they noted that survival was about 80 to 79% in those patients who ended up receiving ECMO. So this was followed by the second major landmark trial for ECMO, was the Eolia trial back in 2018. This was like a follow-up on the Caesar trial, answering some of the questions that kind of were generated at that time. So whereas that was a single center study, this was more of a multi-center randomized trial of BV ECMO versus standard of care. 64 centers primarily utilized in France. Primary outcome that they're looking for is, you know, a mortality difference that they were looking for. And in the ECMO group that they noted, 35% probability of survival versus mortality versus control group was about 46%. The difference was noted not to be statistically significant, and the trial was stopped for futility purposes. However, when they looked at the post hoc Bayesian analysis of this Eolia data, that they showed that yes, there was a high likelihood of ECMO survival benefit, and the recommendation was that yes, ECMO saves lives essentially. So the question here was, you know, what is the experience that we've had with patients with acute respiratory failure on COVID prior to the pandemic? And that was one of the questions that I wanted to ask. And looking at one of the major meta-analysis studies that was done, this basically what they did was, they basically just combined. So they basically just as a meta-analysis, they basically combined the Caesar trial and the Eolia trials, and kind of looking at mortality difference to answer the question of, you know, what's the mortality prior to COVID. Essentially, that's what I was asking. When you look at the study, so when you look at the study itself, comparing the ECMO arm to the conventional group arm, they looked at day 90 mortality. With the ECMO group, they noted there was 36% mortality at day 90 versus 48% in the control group. So that answered that specific question. My next question was, you know, what has been the experience of ECMO utilization in COVID era in terms of mortality, and how the other institutions have been doing? This question was kind of born out from the fact that, you know, at least in the recent past, when we've been taking care of these COVID patients on ECMO, you know, they're not doing well. You call thoracic surgery, you ask them to get the ECMO consult done, and then, like, low-key, you kind of know that they're probably not going to survive. And it's been so dismal and so disheartening that I kind of just looked at what the institutional outcomes in the United States and across the world have been in regards to managing these patients on ECMO. So initially, just when the pandemic started, these were some of the case reports and case series that came out of China, looking at ECMO management versus conventional management. The data was pretty dismal. They noted that ECMO 94% mortality was noted versus conventional management 71%. However, there was no statistical significance between the two. So basically said it was not helpful. However, since multiple studies have been published since then in regards to our COVID experience, and one major study, this was a bit earlier on, was the Paris experience, in which it was published in Lancet Respiratory Medicine, August 13, 2020. What they looked at was adult patients with COVID-19 severe ERs requiring ECMO admitted to any basically one of the major ICUs across Paris, in the greater Paris area, between March 8 and May 2nd, 2020. Inclusion criteria that they was looking was, you know, fulfill the eligible criteria used in ECMO arm of the Eolia trial. Ended up including about 492 patients, which were included, and they were followed up for about 60 days. Looking at some of the important patient characteristics prior to the study, you know, these patients were very sick. Their mean PF ratio was 62, which was significantly lower than the Eolia trial at 73. Compliance, driving pressure were all very similar from that nature. And what they noted was that estimated 31% probability of day 60 mortality and 36% probability of day 90 mortality that they didn't know. So it was pretty good that they noted. Moving on forward to looking at the United States experience that we've had in regards to ECMO. This was a study published in February of 2021. It was a multi-center cohort study of 119 COVID positive patients receiving ECMO over 35 different hospitals. What they were looking was basically day 60 outcomes, day 60 outcome in regards to it. And they noted that, again, fairly good numbers that they were getting, 33% mortality, very consistent with the pre-COVID era mortality data. In this study, they continued on and did what is called an emulated clinical trial, because we don't have a randomized clinical trial looking at post-COVID era mortality, ECMO versus non-ECMO. And based on this emulated clinical trial, they noted that mortality with ECMO was about 34.6%, and mortality without ECMO was about 47.4%, generally pretty consistent with the pre-COVID era data. And then obviously the study that we've kind of all heard about, pretty popular one more recently, was essentially the RUSH trial that was done. This was published in JAMA Surgery about August 2020. Enrolled patients between March and July 2020. Included patients from Advocate Christ and the Rush University Medical Center. Again, similar criteria based on the earlier trial for patient selection, and the primary outcomes that they're looking at survival following discontinuation of ECMO and mechanical ventilation. So the only thing was that this was a smaller study done with 40 patients. Looking at the patient characteristics, they were very sick patients, very sick. Mean age was about 48. And then, from their medical history, they had the whole gamut of medical issues that typically plague these patients. In regards to their ventilator settings, most of them were on 100% FiO2. PEEP levels, if you look at it, there was 17. The plateau pressures were in the low 30s, and then the PCO2s were in the 71s. So fairly sick patients. Most of them were getting pronated. Most of them were getting paralyzed. When you're looking at the timeline in regards to the treatment of their care, most of them got intubation within, first several days, within the first week, essentially, of them being there, and ECMO initiation occurred soon after. The important thing about them was that in the majority of these patients, 88% of them, they were able to extubate them pretty early on, within 13 days on general, and ECMO decannulated, we were able to do it as well. This is kind of the same graph looking at that. All 40 patients at the top were initiated with ECMO, and then it's quite a significant majority of them were able to do an early extubation for these patients, and the vast majority of them were able to decannulate them and then discharge them from the ICU. All 40 patients completed reporting. The important thing to remember is that 82% were alive and went home. So that was pretty significant, and it's a bit of an outlier. This is something that has not been consistently shown everywhere else for the other studies. So couple of things that they did different that may be associated with such improved mortality. Number one, that they utilized a different cannulation technique. This was it was a double lumen single site cannulation of utilizing a Protect dual catheter, which I had not heard about previously. Basically, this catheter, it has an inflow tract that sits in the right atrium, and then the outflow tract, which comes out at the pulmonary artery, and it's got this nifty little band thing that you can utilize. It helps with, early extubation and then physical therapy, etc. They can be utilized for that. Additional thing that this catheter was able to do, since the outflow tract is in the pulmonary artery, it does provide a little bit of right ventricular support as well for some of these patients. The additional things that they utilized that were different was they utilized direct thrombin inhibitors instead of normal heparin. All these patients used higher dose steroids. All the patients got inhaled nitric oxide utilization, and then of course most of these patients were able to get early extubation and physical therapy. Anyone who's been dealing with ECMO and then early extubation, we know that especially with these COVID patients, they have such high respiratory drive. So I'm sure extubating them early and managing them with physical therapy, this sounds like a pretty enormous task, especially because you need to give them appropriate sedation and calm them down to allow them to participate in physical therapy. And then many of these patients are extremely labile, and that any type of movement would result in hypoxemia. So it was clearly a very very involved process requiring a lot of people, and maybe somehow in this formula there is some evidence that that helped some improve their mortality compared to the other studies that have come out. This was a study that came out more recently. This is only about 3.5 weeks ago. This is the Chilean experience. In this study, it was a nationwide Chilean cohort study. So Chile has like a national healthcare system. What they did was, hey, we're going to look at these ECMO patients we've been managing on COVID. So they set 13 ECMO centers across the country that were going to be utilized for ECMO, and all the patients were kind of referred from there. This was published in the Blue Journal on April 6th of this year. It was a population-based study between March 3rd and August 31st, 2020. Again, they noted that, hey, Chile is a resource-limited country, so it was something that they had made a mention of. And looking at the mortality data here, 90-day mortality was pretty good, very significant, similar, consistent with the pre-COVID era. 38.8% mortality was noted, and very similar to previous studies that have been shown. Once they, looking further on, when they separated the patients based on how long they required ECMO, essentially some of them got greater than 10 days and some of them got less than 10 days. We know from previous experience that early utilization of ECMO does have an effect on mortality. However, in the study that they showed that there was no statistical difference whether the patients got early ECMO or later ECMO. And if you're looking at some of the complications that these patients had, very similar across the board. There was nothing new that they came up with that was not present previously. This was the ECMO experience in Europe and Israel. This included, again, a very large cohort of patients, 1,531 patients included, 177 centers across Europe, included centers not included only in the ELSO, they were included outside as well, published in January 2021. This one showed a little bit different, increased mortality, about 45% was noted in these patients. Looking at the international experience, so most of the data is available on ELSO in regards to how these patients are managed in terms of mortality. So looking at all those patients that were referred to ELSO, they published the international experience. Looking at the ELSO registry data, published September 25, 2020, it acquired very large cohort of patients, 1,035 patients to be exact, 230 centers, 36 countries between January to May 2020. Primary outcome that they're again looking for 90-day mortality, and again, pretty good. 90-day mortality was noted about 37.4% on these patients. Now, additional thing to note is that ECMO, ELSO keeps an active registry of all of these patients who were COVID on ECMO on their active website. This is taken from their website last week. So that mortality had creeped up to about 49% now. And this has been a trend that has been noted across the board in all the other previous studies, that in the first wave of the pandemic, there was an improved mortality or the mid-30 percentile, and that has since increased to about 40% since then. Looking at some of the patient characteristics of those 4 major trials that I kind of talked about, this is the Chilean experience, the Paris experience, the international ELSO experience, and this is the US experience. Age of the patients are kind of similar in the late 40s. If you're looking at pre-ECMO parameters, they were all very similar in their sickness. The RESP score was pretty similar across the board. SOFA scores were similar. Majority of the patients were getting prone and paralyzed. Most of them, except for the Chilean study, had very higher levels of PEEP, between 14 and 15. PEEP was kind of low on the Chilean side. That was the only one that was different. In regarding the PF ratio, the PF ratios were all across the board very low. EOLIA trial had about 73 PF ratio. 87 was noted on the Chilean study. So the only thing about the Chilean study was the patients were not as sick compared to the other ones. And then, however, if you look at 60-day and 90-day mortality, kind of remained the same. So, next question is, what are the factors commonly associated with mortality in these COVID patients, and it's kind of different compared to the pre-COVID era. Just a little bit from before, just a little background. Normally, when patients are placed on ECMO, you can calculate mortality scores and see how they're kind of doing. 2 major scores which are utilized is the RESP score and the PRESERVE score that they utilize. The RESP score was kind of validated back in 2014. In the RESP score, there are certain parameters which typically utilize. Age has always been characterized as something that's utilized. Patients' immunocompromised status has an associated with worsening mortality. Mechanical ventilation prior to initiation of ECMO within 1 week or after 1 week the etiology of the ARDS that's associated with it as well. Then, of course, nitric oxide before utilization, your muscular blocker, PCO2 levels, these are all included. The estimated survival, the higher the RESP score, the higher the survivability of these patients. So plugging it in for their typical COVID patient, you'll have, between 50 and 59, their age group at that time. If let's say they're not immunocompromised and they're within the first week they are placed on ECMO, they're getting paralytics and PCO2 is at 75 and peak and spring pressure is pretty high, then estimated survivability should be anywhere between like 50 to 60% based on this RESP score. The next score is the PRESERVE score, which is utilized in the PRESERVE score. The higher the PRESERVE score, the worse the mortality is for these patients. So again, some of the similar parameters are utilized: age, immunocompromised status, days on mechanical ventilation, how sick they are, the SOFA score, proning, and PEEP. These are all utilized as well. Interesting to note is that whereas the RESP score does not mention anything about a BMI or how larger these patients are, PRESERVE score does mention it. However, in a negative sense, that it seems like the higher the BMI, the better they're doing. I'm not exactly sure. So that's pre-COVID era. So when they looked at the Paris cohort study and they tried to look at, they built a multivariable Cox model for factors associated in hospital mortality in patients with COVID, some of the, same suspects were identified. Increasing age was clearly associated with worsening mortality. The patients were immunocompromised, also associated with worsening mortality, worsening respiratory disease, pre-ECMO cardiac arrest, presence of AKI, and if their initial mode was ECMO, was VA ECMO, was also associated with worsening mortality. Next, one additional thing that they did note was what has been known from before is that centers which are frequently associated with large ECMO volume have been noted to have improved mortality. This has been noted. This is from like a 2013 study of looking at the ELSO experience of these ELSO centers. They looked at patients who did ECMO for centers who did ECMO for neonate, pediatric, adult ICU patients, and it was first noted here that institutions that do a larger number of 30 or more of ECMO per year were generally associated with improved mortality. And this is basically like a volume outcome relationship we were talking about, that if you have a higher hospital volume, your organizational structure is there, you have ECMO coordinators, et cetera, you have the appropriate staffing, equipment, expertise, improved quality of care that's delivered, you have lower patient mortality, and then more ECMO referrals, this kind of positive feedback referral. And then based on this, the WHO recommended that when COVID hits, essentially, generally patients with sufficient ECMO volume should maintain proficiency and should continue to do ECMO on these patients. So I wanted to see if this volume outcome relationship has been preserved since COVID has started. So looking at the Paris cohort study, the Paris experience previously, again, in the greater Paris area, they utilized 17 ICUs in that study. 3 ICUs managed at least 30 patients within the past 1 year. 3 ICUs managed about 10 to 30 patients, and about 11 ICUs managed less than 10 patients. Now, when they looked at mortality difference based on the institutions and how often they were utilizing ECMO, so they did note that there was a statistical significant difference between centers that did more than 30 venous ECMOs in previous year. That was present, that was noted. So again, same thing, looking at the graph here, that caseload in previous year, if there's associated less than 30 versus greater than 30, there's quite a significant difference noted, in addition to the normal, normal mortality that's come out. So that's kind of what it comes down to, that perhaps if our volume is much greater, if that may be somehow contributing to some of the difficulties that I've personally noted. The next question that I kind of wanted to look at was in regards to ventilator management, because I'm always confused about what kind of ventilator management do you place these patients once they are put on ECMO. So what are we aiming for? What are the current guidelines, if there are any? What evidence that we have available to support these guidelines, and what are the major institutions that are ECMO utilizing in regards to the ventilator management of these patients? So obviously we've known for a long time, for like 2 decades or so, that this concept of baby lung, that with this acute respiratory failure, these patients have very small effective amount of lung available for ventilation and oxygenation. So you're doing a baby lung type of ventilation on these patients. And then the goal of mechanical ventilation on ECMO is number one, obviously, to achieve viable gas exchange. However, by alleviating some of the pressure on the lung, you're allowing the lung to rest, you're allowing the lung to heal. When you're looking through the data, there doesn't seem to be any optimal ideal strategy for ventilation. It seems to be kind of unclear and kind of all over the place. No evidence-based guidelines for mechanical ventilation patient ECMO that I could clearly discern. When you are managing these patients on a ventilator, there are a couple of factors that you keep in mind. One of the objectives is, hey, you've got to limit alveolar strain. You limit the strain by some of these institutions now are recommending something called an ultra protective lung ventilation strategy, utilizing tidal volume less than 4 mg per kg for their ideal body weight, and keeping peak and spree pressure less than 20 to 25, and then you decrease the respiratory rate as well. You prevent telec trauma by keeping higher levels of PEEP. Obviously, preventing resorption atelectasis by decreasing FiO2 and then preventing over distension as well. So this is the current guidelines which are available. So per the ELSO guidelines, currently recommend obviously FiO2 less than 40. You keep plateau pressures less than 25. Generally, PEEP are kept on the higher side. Respiratory rate is also kept on the lower side on these patients. Per the CSER trial, they kept the FiO2 also pretty low. PEEP levels were maintained on the higher side between 10 and 15. The peak inspiratory pressures in the CSER trial was also between 20 and 25, and the respiratory rate is generally kept at also low at around 10. Similar things were noted on the EOLIA trial. The only thing about the EOLIA trial was did not regulate the respiratory rate at all. So patients were all over the place from between 10 to 30 breaths per minute. However, we do know that there's a contribution of ventilator-induced lung injury associated with increasing respiratory rate as well. Once you come down to that question of mechanical power that is administered to the lungs and the risk of ventilator-associated lung injury. So tidal volume obviously is a component. Respiratory rate is also a component to it. This was an international multi-center prospective cohort study of ECMO centers that are registered and also who are managing these acute respiratory failure patients. When they looked at the total mechanical power that was delivered pre-ECMO versus day one of ECMO, like noted right here, there's about 75% decrease noted in the mechanical power that was delivered once you put them on ECMO on ECMO. So now looking at individual ventilator parameters, looking at tidal volume on itself. So the only study that I could kind of really find in looking at specific tidal volume and its effect while these patients are on ECMO. So this was a bit earlier study in 2013, looking at ultra lung protective strategy of lower tidal volume, about 3 mg per kg, augmented with ECORS, so extracorporeal CO2 removal, versus conventional mechanical ventilation at 6 mg per kg. In this randomized clinical trial, that they did note that there was there was no difference when you look at overall outcomes in terms of ventilator-free days and then their free days at day 60. However, when they did a subgroup analysis of patients who were extremely sick, the P2F ratio less than 150, that they did note that there was significant improvement in ventilator-free days and ventilator-free day 60 when they used this ultra lung protective ventilation strategy. This has been kind of borne out if you look at the international experience, what these ELSO centers have been doing. So looking at the red, which is the pre-ECMO time, and then once the blue is once they get placed on ECMO, and then looking at the tidal volume specifically into it. So you know that about less than 10% are actually utilizing the 4 mg per kg or less ventilators strategy tidal volume. However, once they get placed on ECMO on day one, they're able to get to 65%. 65% are able to get to it. Then next comes to respiratory rate. In regards to respiratory rate, I really did not find much that was available. There are a couple of animal studies looking at patients, looking at animals that were put on set tidal volumes, and one variable had a higher respiratory rate versus the other, and then the BLs and looked at it, and they noted that there was increased inflammatory markers that were noted on the BL on patients who had a higher respiratory rate compared to those with a lower respiratory rate in animals with a different respiratory rate. However, looking at the previous two studies, the lifeguarded periods and the EOLIA trial in itself, and the noting of the total mechanical power that was reduced after these patients were placed on ECMO, not only was the tidal volume significantly improved, a significant chunk of the decrease in mechanical power kind of came from the respiratory rate itself as well in these patients. So there's something to be said about that. Now, obviously, when we talk about PEEP on its own, we've just kind of switched more leaning towards an open lung strategy, because obviously we're decreasing tidal volume, we're increasing the risk for anaphylactic trauma that would be present. So you kind of manage their higher levels of PEEP. That's something that we need to keep in mind. Again, no real obvious data that was available in regards to mortality difference with utilizing higher PEEP. This was kind of something that was present that kind of came out. It was a retrospective international multi-center study looking at higher PEEPs in patients during the first 3 days on ECMO, and if there was noted to be any independent associated with improved survival that they were able to find. So generally used like a PEEP of 10 or greater. This is the only thing that I could really find on it. Of course, when we talk about increasing PEEP or decreasing tidal volume, you're actually talking about decreasing driving pressure. We're all familiar with the New England Journal study from 2015 showing that driving pressure less than 15 obviously associated decreased relative risk of death, essentially. So once they looked at what the other institutions across the United States who are also registered were doing in this same multi-center prospective cohort study, when they looked at the driving pressure, 15 was generally noted in about 30% of those patients, 30% or less. And that kind of increased to about 68% once they were placed on ECMO. So they were pretty successful in bringing down that driving pressure. Looking at driving pressure alone in terms of mortality, this was a meta-analysis of observational studies in adult ARDS patients receiving ECMO for refractory hypoxemia. They looked at 9 studies, including 545 patients that were included. Primary outcome, again, looking for in-hospital mortality in these patients. They looked at those patients who were on ECMO who lived, those ECMO who died, and they looked at the difference in different ventilatory parameters, tidal volume, PEEP, respiratory rate, et cetera, FiO2, and looked at driving pressures, P2F ratios. When they looked at these 2 things, in addition to the normal usual suspects of mortality, including higher age, male gender, lactate levels, the only ventilatory parameter that they were noted to find that improved outcomes was, driving pressure was associated, increased driving pressure was associated with worsening of mortality in these patients. Now, looking at what other institutions have been doing, about 30% of these institutions actually have a protocol for managing these patients with mechanical ventilation, and looking at their ventilatory parameter targets. This was a study just kind of looking at those targets. 77% are actually utilizing a lung rest strategy actively, and then 18% are using a lung improvement strategy. When they looked at the tidal volume, ultra lung protective volume strategy, 35% of these institutions actually targeted the tidal volume less than 4 meters per kg. And the PEEP targets, only 22% are targeting PEEP greater than 10, but about 60% or so were targeting between PEEP of 6 and 10 or greater. And of course, when we talk about weaning, the majority of these institutions kind of have been weaning off ECMO first, and then kind of weaning off the ventilator later, as opposed to the other way around. The other question that kind of came up that I thought about was ECMO and proning, right? So we know that based on the Perceiver trial that proning helps, it saves lives. And then we also know per the Eolia trial and Caesar trial that ECMO saves lives. So what if you combine the two? Would there be any improvement in mortality based on ECMO and proning as well? So the only thing that I could find here was this retrospective observation study of 168 patients that were supported by VV ECMO for severe ARDS. What they did was essentially divided the patients into 2 patients who got ECMO alone and versus who got proned and ECMO at the same time. When they looked at it, they're looking at significant mortality difference from 30-day, 60-day, and 90-day mortality. There was improvement in mortality data in those patients who got proning and ECMO at the same time, as opposed to looking at survival, as opposed to just ECMO alone. So, so there may be something to be said about that as well. So in conclusion, obviously utilizing ultra lung protective volume strategy, tidal volume strategy, keeping plantar pressure less 25, obviously decreasing respiratory rate, keeping higher levels of PEEP, and possible role of proning while these patients are on ECMO. Yep. Thank you.